For the next lunch symposium, the topic is targeted therapy in moderate to severe ulcerative colitis, supported by Janssen company. The moderator is Professor Varocha Mahachai. So please welcome Professor Mahachai.
Ladies and gentlemen, so we start our next mini symposium on targeted therapy in moderate to severe ulcerative colitis, supported by Janssen company. And we are very fortunate today to have Dr. Waqqas Afif from McGill University in Montreal, Canada. He is currently Associate Professor in the Department of Gastroenterology at McGill in Montreal, Canada. And he is a McGill IBD Center Research Director and the Montreal General Hospital GI Site Director. So before presentation, I like to say hello to Dr. Afif. And we greatly appreciate your kind contribution to our meeting. IBD is becoming increasingly common in this part of the world, in ASEAN countries, and we have many newer agents become available. So we like to hear your presentation on that. So, and thank you very much for stay on live. It's 2:00 in the morning in Montreal. So thank you, and he will stay live during Q&A. So if any of you have any question, please feel free to add in the chat box. So thank you very much. So how is the weather in Montreal now? It's okay?
It's good. It's a little bit cold. Thank you for the invitation to present today. It's my pleasure.
Okay, so we start our presentation now by Dr. Afif, please.
Thank you very much for the invitation to present today on targeted therapy in moderate to severe ulcerative colitis. My name is Dr. Waqqas Afif. I'm an Associate Professor of Medicine at the McGill University Health Centre in Montreal, Canada. Here are my conflicts of interest. So we know that ulcerative colitis is a chronic and progressive disease. We know that chronic inflammation can lead to bowel damage and structural changes of the colon, including widening of the submucosa due to fat deposition, luminal narrowing and strictures, as well as shortening and stiffening of the colon, which can eventually lead to a lead pipe type colon. We know that if we have active endoscopic disease, that the risk of colectomy is higher. And so one of our treatment targets, which we'll talk about in a few minutes, is mucosal healing. If we can get to mucosal healing, the rate of colectomy is about 10% less in those patients that we can achieve endoscopic remission as compared to patients that were unable to achieve endoscopic remission. So we know that ulcerative colitis causes significant disruptions to patients' lives. It leads to a loss of autonomy. 80% of patients believe that ulcerative colitis prevented them from leading a normal life. About 2/3 of patients, 3/4 of patients, reported feeling depressed as a result of having ulcerative colitis, and 85% of patients worry about the long-term side effects of their disease. And so what are our treatment guidelines or treatment goals? So these are the STRIDE-2 guidelines, looking at treat-to-target strategies in inflammatory bowel disease, specifically ulcerative colitis here. And so we know that if we have someone diagnosed with IBD and have active disease, that our first treatment target is symptomatic remission. That's a short-term target. And then we hope for not only symptomatic remission, but normalization of CRP and fecal calprotectin. And these are more intermediate targets. And our final long-term target is endoscopic healing, a normalized quality of life and absence of disability. And for ulcerative colitis specifically, there is some data emerging that histologic healing may be an endpoint as well, but not yet in clinical practice. So these are the specific recommendations for ulcerative colitis in terms of the STRIDE-2 guidelines. You can see here there's an immediate goal, which is a clinical response, which is a 50% decrease in the PRO2, which includes rectal bleeding and stool frequency. There's the intermediate target, which includes clinical remission, but also, as I mentioned before, normalization of CRP and fecal calprotectin. And the long-term goal, of course, is endoscopic healing with a Mayo endoscopic subscore of 0. And this, along with absence of disability and normalization of health-related quality of life. In terms of the time required to achieve these goals, in the STRIDE-2 guidelines, they do suggest some timelines, and you can see them here. You can see that for the biologic medications, they're approximately the same with some minor changes. But that long-term target of endoscopic healing happens anywhere between sort of 13 and 18 weeks. So what are the current treatments for ulcerative colitis in 2021? So we know that we all use conventional therapy. So 5-ASA agents, which work for about 50 to 60% of patients, whether that's orally or topically. Immunosuppressants, which we are using less and less of, and corticosteroids, more so as an induction agent and not a maintenance agent. There are several biologic therapies available, including the anti-TNFs, which you're familiar with, including infliximab, adalimumab, and golimumab. There's new medications available as well, which you're likely familiar with, including vedolizumab, ustekinumab, and then we'll touch briefly also on tofacitinib and ozanimod. And still, in a certain subset of patients where we're not able to get the disease under control, the long-term treatment is surgery, which includes an ileal pouch anal anastomosis or an IPAA, or a permanent stoma or an ostomy. So in terms of the current standard of care, we still use a step-up therapy where we start off with 5-ASA agents, and if that doesn't work, we move on to corticosteroids. As I mentioned before, we're using much less immunomodulators, and quickly moving on to biologic agents or oral small molecules. And again, if that fails, then we move on to surgery. In terms of the different mechanisms of action in IBD, the different targets, you can see them here in this diagram. You can see all the different targets that are available and more on the way. And so what are the current options available? So you can see here there's anti-TNFs, anti-integrins like vedolizumab, the JAK1/3 inhibitors such as tofacitinib, and IL-12/23, which we'll touch on a little bit more in the next few minutes. In terms of what's in development, JAK1 specific inhibitors and specifically anti-IL-23 inhibitors are in development in phase 3 programs, and S1P modulators. There's one that's currently approved, at least in the United States, and others on the way, and we'll talk about that as well. So in terms of the current available treatments, so most of us are familiar with the anti-TNFs. They work well, they have a rapid onset, and we have lots of experience with them, but there are some risks associated with it, including the risk of malignancy and infections. There's a loss of efficacy over time, mainly due to the risk of antibody formation and immunogenicity. And there's an inadequate steroid-free remission at 1 year. More and more, we're using anti-integrins, such as vedolizumab, which has a more unique MOA specifically targeting the gut, and it's a very good safety profile. There are some risks, including the fact that it does have some immunogenicity associated with it. The JAK inhibitors, which were recently approved, are oral, they work well, and they are non-immunogenic, but there are significant risks associated with it, including the higher risk of infections, particularly herpes zoster, the higher risk of venous thromboembolism, and then there's some off-target effects as well. And so finally, the medications that we'll talk a little bit more about are the anti-IL-12/23s, specifically ustekinumab. These work well. They have efficacy in biofailure patients as well as bio-naive patients. They can be given in monotherapy. And they have placebo-like adverse events. In terms of risks, not many risks associated with it. We have a little bit less safety data with the anti-IL-12/23s compared to other medications that I spoke about. So in terms of what we have available now, this is sort of just a summary, and again, some caution advised in terms of comparing across clinical trials, but just to show you that the delta in terms of patients achieving clinical remission is about 10 to 15%, regardless of whether you look at the JAK inhibitors or vedolizumab or ozanimod, which is the S1P inhibitor, which we'll speak about a little bit later. In the infliximab patients, you can see here the delta is a little bit higher, but remember that these were all bio-naive patients. And so just in terms of what's coming on the market or what's new, you're all familiar with this pathway, which is for vedolizumab, so the anti-alpha-4 beta-7 pathway. There was some initial phase 3 studies looking at etrolizumab. Unfortunately, because of some unfavorable results, the etrolizumab program is on hold at this moment. At this moment, there is phase 3 anti-MAdCAM trials that are going on at this point as well. But just to sort of give you a little bit of a, what's new in terms of this pathway. So recently, the sub-Q formulation was approved, and this was based on the VISIBLE-1 study in ulcerative colitis. And you can see here that they compared sub-Q IV vedolizumab versus sub-Q vedolizumab. Everyone got a week 0 and 2 IV dose induction, and then either continued on sub-Q therapy every 2 weeks or the usual IV vedolizumab 300 milligrams every 8 weeks, or placebo. And you can see here that there was no difference between the IV or the sub-Q group, and the results are very similar to what we saw in Gemini 1 in terms of patients on vedolizumab for ulcerative colitis. So another sort of option for patients is using subcutaneous vedolizumab instead of IV. In terms of the JAK inhibitors, we all know that tofacitinib is available, which is an oral small molecule JAK inhibitor. It works relatively well, although there are some side effects associated with it. The hope is that more targeted JAK therapy, so this is some data that was presented at UEG this year, might be equally as effective and perhaps have a better safety profile. And these are the results from upadacitinib trials. And you can see here the primary endpoint was reached. And so hopefully in the next year or so, this will be approved and be available in clinical practice as well. I mentioned S1P modulation. So this is a new mechanism of action. So S1P modulates the inflammatory pathway by regulating the egress of lymphocytes from lymph nodes. And we know the lymphocytes are the cytokines causing inflammation and travel to sites of inflammation in patients with IBD. And so the thought is that if you have an S1P inhibitor, you limit or reduce this egress of lymphocytes into the circulatory system and decrease the inflammatory load. And so what data do we have for this? So this is for ozanimod, which I mentioned before, was recently approved by the FDA in the United States and is currently available in clinical practice. This is the induction data showing that there's benefit over placebo in terms of clinical remission and endoscopic remission as well. This is the maintenance data, again showing a significant improvement in terms of clinical and endoscopic remission compared to placebo. So another option that's available for patients with ulcerative colitis. So I want to focus a little bit more on ustekinumab, as was asked by the organizers. So we know that ustekinumab targets the P40 subunit, and so it has effects on IL-12 and IL-23. And we know that the IL-23 pathway is an important pathway, not only in IBD, but also in psoriatic arthritis, psoriasis, enthesitis, and uveitis. And so we think that this is a very central pathway in terms of limiting inflammatory disease. So whether it's in the skin or in the gut or in the joints, IL-23 plays an important role in terms of these different disease processes. And so inhibiting IL-23, either directly with an IL-23 inhibitor, or in this case with an IL-12/23 inhibitor, is going to be beneficial. And so we know that there's dysfunctional interaction between the environment and host genetics. which leads to this hyperexpression of IL-23, and this leads to the chronic inflammation that we see in all these autoinflammatory diseases such as psoriasis and psoriatic arthritis. And the thought is that if you reduce IL-23 with these inhibitors, you restore the immune homeostasis and avoid safety side effects of broad immunosuppression that we see with anti-TNF, particularly serious infections. And so let's talk a little bit more about the phase 3 program for ulcerative colitis with this IL-12/23 inhibitor, ustekinumab. And so you can see here, this was the induction study comparing placebo versus 6 milligrams per kilogram, 1 IV dose, and you can see the primary endpoint here is clinical remission. And those patients that responded at week 8, or those patients that were in remission, randomized to the maintenance study. These are the baseline demographics. You can see here that patients had relatively high median Mayo score of about 9, and about 15% had a more severe Mayo score of greater than 10. The fecal calprotectins were quite elevated, more than 1,000. About a third of the patients had previous anti-TNF failures, and then another 15% or so had failure to not only to anti-TNF but also to vedolizumab. In terms of the medications at baseline, about half the patients were on corticosteroids, a third of the patients were on other immunomodulatory drugs, mainly azathioprine, and about 70% of patients were on 5-ASAs. They included another endpoint called histoendoscopic mucosal healing, which was basically endoscopic improvement along with histologic healing. This is one of the first phase 3 studies that combined these two, leading to this new endpoint of histoendoscopic mucosal healing, which the thought is, might lead to better overall outcomes in the long term. So here is the maintenance part of the study. So those patients that responded or were in remission were randomized at week 8 to either get placebo, 90 milligrams Q12 weeks, or 90 milligrams Q8 weeks. So this is important because of the high placebo rates that you'll see during the results section. But remember that the placebo patients here actually did get an IV induction, so they all have drug on board during that maintenance period. And the primary endpoint, again, was clinical remission. So here are the results in terms of the induction study. So here's the change in the partial Mayo score through the first 8 weeks. You can see here that it works relatively quickly, and you see changes in the partial Mayo score as early as week 2. And you can see changes in the CRP and fecal calprotectin as early as week 2, and sort of increasing at week 4. And so these are the data in terms of looking at clinical response. You can see about 70% of patients in the non-biologic failure patients responded, whereas 60% of patients in the biologic failure patients responded to ustekinumab. And in terms of remission, again, you can see there was a significant, about 10% delta of patients getting ustekinumab compared to placebo. And that endpoint of looking at histoendoscopic mucosal healing, you can see here that just one single IV dose, you can see about 20% of patients were able to achieve that outcome of not only endoscopic response, but also histologic response. So one of the important things in the study is that those patients that got the IV dose and didn't respond got one additional dose at week 8. These were patients that were not completed part of the maintenance study, but just were followed over time. And you can see here that there is about a 20% increase in the amount of patients that were able to get into response or remission after that first sub-Q dose. So something to sort of think about in clinical practice, that even those patients that don't respond or are not in remission after week 8, giving them that first sub-Q dose at week 8 and waiting till week 16 seems to increase the rate of patients in response or remission by about 20%. So something to look into practice before making changes, that you might want to wait until week 16 before making any changes in therapy. And so this is the maintenance data. You can see here, again, compared to placebo, there was about a 20% delta. in patients that were on every 8 weeks. Again, remember that the high placebo rate here is probably due to the fact that these patients also did get that first IV ustekinumab dose. But again, compared to placebo, whether it was biologic failures or non-biologic failures, there was improved clinical remission, especially in the Q8 week group. What about steroid-free remission? So most patients, 97% of patients that were in remission were also steroid-free at week 52 compared to placebo. So that leads to about a 43% corticosteroid-free remission rate. And if you're able to get into remission, this is looking at symptomatic remission over time, you stayed in symptomatic remission over time, and there was not much of a loss of response in these patients. What about endoscopic improvement? Again, you can see here compared to placebo, again, a significant improvement in terms of endoscopic improvement. So about 50% of patients at week 52 had some degree of endoscopic improvement. And again, a large percentage of patients also had histologic improvement at week 52, sort of in that 50 to 60% range. And that combined histoendoscopic mucosal healing endpoint that I was talking about, also here compared to placebo, there was a significant improvement in terms of patients achieving that histoendoscopic mucosal healing, which was endoscopic healing, so a Mayo endoscopy subscore of 0, and along with histologic healing. What about immunogenicity? So we know that for anti-TNFs, immunogenicity is a major issue with rates of antibody formation sort of in that 20 to 30% range. And here you can see that in the ulcerative colitis subgroup, the rate of antibodies was quite low, sort of in that 1 to 5% range. And the serum ustekinumab concentrations were unaffected by any immunosuppressive therapy in those patients that were on immunosuppressives. You can see here that for the Crohn's disease subgroup, in the Unity trials, again, the incidences are quite low. So quite reassuring that the rate of antibody formation is quite low in ustekinumab compared to the anti-TNFs. So in terms of key safety findings, so really nothing to be concerned about. There was really no increased risk of infections. In fact, the placebo group had a higher rate of infectious complications as compared to the rate of complications in the patients that were on ustekinumab. And so this is newer data that was published at UEG this year, again, looking at symptomatic remission through 3 years, or at 152 weeks. And you can see here that, again, those patients that are in remission tend to stay in remission, again, sort of highlighting the fact that the immunogenicity with this drug is quite low, and that if you're able to get into some degree of remission, that you'll be able to stay in that remission on monotherapy without having an immunosuppressive on board. This is the safety data, again, showing that there is no concerning findings in terms of safety after 3 years of treatment. So in summary, 1 single IV dose followed by maintenance dosing. You can see the recommended doses here. And you can see here that after that first IV dose, most patients would get every 8 weeks. And there are a subset of patients that can actually tolerate every 12 weeks as well. So if you have a very low inflammatory burden, it might be worthwhile to consider every 12 weeks. In certain jurisdictions, Q4 dosing is available. So particularly after 16 weeks, if the patient's not doing well, you can move to every 4 dosing in certain jurisdictions. And just like in Crohn's disease, there's the option of either of also giving an IV ustekinumab reinduction. Again, that's not available in all jurisdictions, but certainly available in certain jurisdictions. So before we move on, I just want to sort of highlight that there are other drugs coming on board. So remember, ustekinumab is an IL-12/23 inhibitor, which targets the P40 subunit, and there are newer drugs that inhibit specifically the P19, and we think that IL-23 is the main cytokine and not IL-12, and so there are new medications that are available or that are coming down the pipeline in terms of inhibiting specifically P19 and IL-23. And so here's a list of them here, including risankizumab, guselkumab, and mirikizumab. Mirikizumab is in phase 3 studies, along with the RISA and guselkumab for ulcerative colitis. So new agents coming down the market. We know that in patients that have psoriasis, that the patients that receive, and there's been a head-to-head clinical trial comparing IL-23 versus an IL-12/23, and risankizumab in this specific case did much better than ustekinumab in patients with psoriasis. The question is, in ulcerative colitis, are we going to see this dramatic increase in efficacy with specifically the IL-23? So it's something to look forward to in terms of further studies. So in terms of the options that are currently available, here's a list. I didn't include ozanimod here just because it recently came out. But you can see here that they're all equally effective. They all have a very rapid response. In terms of what differentiates them, mainly it's safety at this point. So the newer medications, including ustekinumab and vedolizumab, don't have a black box warning in terms of the risks of infection or malignancy. And so there is sort of a thought that maybe using these agents that have a better safety profile might make them more first-line agents compared to the anti-TNFs. But in terms of the guidelines, so these are the AGA guidelines, the American GI Association and the Canadian Association of Gastroenterology guidelines, which I adapted. And so you can see here that in patients that have moderate to severe ulcerative colitis despite standard therapies, which includes 5-ASA and corticosteroids, that we use either anti-TNF monotherapy, either alone or combination with thiopurine, or ustekinumab or vedolizumab alone, again, because of the fact that the rate of antibody formation is quite low with the newer agents. In terms of the thiopurines alone, myself, I haven't used thiopurine alone in multiple years. And again, there's very little data for induction, and the maintenance data is there. But because of the safety profile, there's sort of this push away from using thiopurines and using more biologic agents. In terms of the other two agents that are available, again, from a safety perspective, tofacitinib and ozanimod are very effective drugs, but because of from the safety perspective, they've, at least in my opinion, are more second-line agents as compared to the other agents that I mentioned. So how do we have lots of different options. So how do we choose which biologic to use? So there's lots of different factors, including drug factors, clinical factors, patient factors, and physician factors. And so we have a lot of different options, and sometimes it's very difficult to choose one biologic over the other. And so one of the questions that's going to come up is how do we position one biologic versus another biologic, all these options that are available. So obviously we need head-to-head studies, and you're probably familiar with the Varocha study, which looked at patients and compared patients that were either on vedolizumab or adalimumab in anti-TNF naive patients. And so you can see here that in terms of the overall endpoint, and more specifically the anti-TNF naive patients, vedolizumab was the superior agent compared to adalimumab. So something that helps us a little bit in terms of positioning one biologic over the other, in this case specifically vedolizumab over adalimumab. And so at least in my clinical practice, I'm using a lot more vedolizumab compared to adalimumab. And so there's other head-to-head trials that are coming. This is just a small overview of them. And you can see here that all these head-to-head trials will help us. Some of these are in Crohn's disease, others in ulcerative colitis, but all these head-to-head trials will help us position all the different biologics that are coming down the market. There is some data, and I'll just mention this briefly, in terms of looking at dual biologics. So we've been using this in clinic for very refractory patients, and there is some data that combined biologics could be the way to go, just like HIV is treated or hepatitis C is treated, that perhaps a combination of biologics is the way to go in terms of improving outcomes and remission, and sort of break that 20 to 30% delta that we see across multiple agents. And here is the treatment pipeline. You can see here, as I mentioned, obviously the ones that have been marketed, and some of the phase 3 studies that are ongoing. And you can see here that there's a whole host of phase 2 studies as well. So a lot to look forward to in terms of different therapies that will be available for the treatment of ulcerative colitis. And so in conclusion, you can see here that there's a persistent unmet need in patients with ulcerative colitis. In terms of endpoints, we're certainly looking at mucosal healing or endoscopic remission as our endpoint, and perhaps histologic healing in the next few years. There's a move towards safer and equally effective molecules, i.e. ustekinumab and vedolizumab over anti-TNFs. There's already two oral therapies that are approved, including JAK inhibitors and S1Ps. There's more specific JAKs that are coming down the pipeline in the next couple of years. We'll have oral integrins and oral anti-TNFs. So there's a real push towards oral therapy, and we know that patients prefer oral therapy. So things will definitely change in the upcoming years. And so how are we going to position all of these? So we just need more head-to-head studies to help us position all these new molecules that are coming down the market. Thank you very much. If you'd like to reach out to me, you can either email me or reach me through Twitter. And thank you very much again for the invitation. And I will stop here. Thank you.
Thank you very much, Dr. Afif, for the excellent presentation. So now we go to Q&A section. We have quite a number of questions to you. It's a very interesting, and these for the indication UC only become available in Thailand for the last 2 years. And I understand in Canada probably you have used for 5 years already.
Yeah, so we've had ustekinumab for about 5 or 6 years already.
Yes, so question from the audience. First question, role of biologic agent as a first-line treatment in UC or Crohn's disease?
So, I mean, in terms of patients with ulcerative colitis, we still use the 5-ASA agents most of the time as first-line agents. And if those fail, despite 5-ASA and steroids, then we move on to biologic agents. I'm using a lot less of thiopurines, and usually if they fail their 5-ASA, I go on to a biologic for Crohn's disease. Again, because there's no great treatment, we don't use 5-ASAs in Crohn's disease. And so we are using a little bit more biologics as first-line agents in Crohn's disease. I mean, the exception here would be severe ulcerative colitis patient that comes into hospital that needs IV steroids and doesn't respond and needs a biologic agent.
I see.
As first line.
Next question. How long does it typically take a patient to start responding to this new agent, ustekinumab?
It works relatively quickly. Yeah, it works relatively quickly after the IV dose. So you'll start seeing some response within a couple of weeks after you start therapy. But as I mentioned, there are a subgroup of patients that won't respond after 8 weeks, and giving them that extra dose at week 8. So after the IV dose, giving the sub-Q dose at week 8, you'll get another 10 to 20% of patients that respond. So it's worthwhile waiting, that 16 weeks to see how, what percentage of patients respond. But a large percentage of patients will have that initial response. And then you'll need to wait a little bit longer for it to work. And after 16 weeks, if it's not working, then depending on your jurisdiction, you have the option of either giving it another IV dose or changing it to every 4 weeks in a certain subset of patients.
And how long you keep patient on maintenance treatment, and any concern with the side effect, and what is your stopping rule?
So, like most of IBD, so if you're doing well on the agent, because it is a chronic disease, we tend to keep them on the biologic agent. So, if you do well on your ustekinumab, then you pretty much stay on it for long term. There isn't really a great stopping rule with any of the biologics. So we know, at least for anti-TNFs, that even if you're doing well after 3 to 5 years and you try stopping it, there's about a 50% chance of having a flare after you stop it. So for the most part, we like to continue it. In terms of side effects, obviously with the anti-TNFs, we worry about a slightly higher risk of infections, particularly in more older patients. The benefit of the newer agents, particularly ustekinumab and vedolizumab, is that there's no real long-term side effects that we know of at this point, and there's no increased risk of infection. So certainly two medications that we can keep in the long term and reassure our patients that they're relatively safe.
I think you're lucky in Canada that usually it's covered, like can get reimbursed, but perhaps not in Thailand. So the case that continued treatment is be selected cases, that can get reimbursed. And any role of combination treatment, will you use other immunosuppressive agent in combination if you continue these medication, the biological agent, with steroid, with ASA or azathioprine?
So certainly not steroids, because we want to sort of avoid having long-term steroid use. And 5-ASAs we can withdraw. There's no extra benefit of keeping the 5-ASA in patients who are doing well on biologics. In terms of immunosuppressive, so if you're on an anti-TNF, because of the risk of immunogenicity, there may be some benefit of having a concurrent immunomodulator on board. But usually after 6 to 12 months, if you're doing well and you have good drug levels, you can consider stopping the immunosuppressive agent. So the advantage of vedolizumab and ustekinumab is that there is very low immunogenicity associated with these two drugs. And so most of the time, you don't need combination therapy with these drugs, and the risk of developing antibodies is quite low. And again, with the newer oral agents like tofacitinib, there is no risk of antibodies. So, monotherapy is the way to go for those patients as well.
Okay. I think more question coming in. They said about the histological and endoscopic endpoint that you recommend, and the question is, both endpoints, will there be provide additional benefit to current endoscopic endpoint that we regularly use?
Yes, that's still currently being evaluated. So certainly if you can get to histologic healing, we know that leads to a longer term remission and less of a chance of having an acute, flare. The other drugs haven't looked at it specifically. There is some data for vedolizumab and histologic healing as well that's been looked at after the drug has already been on the market. And so, I think if you can get to histologic healing with whatever agent, then that certainly gives you a longer, better term outcome. But, there is a bit more data associated with ustekinumab because it was in the clinical trial. So certainly something to consider. And it's not an endpoint just yet, but maybe in the next few years, hopefully, there'll be enough data to suggest that you have to get to histologic healing to sort of have that better outcome.
Someone asked, do you have any experience of ustekinumab failure and who need to go back to something like ifizumab instead? Yeah,
so we started using ustekinumab, and vedolizumab as first-line agents. And then if they fail that, then sort of moving on to an anti-TNF afterwards. So that does have success. And so if you've given an IL-12/23 and it fails, then you do have the option of going back to the anti-TNF. There hasn't been a lot of studies looking at that sort of pathway, but certainly in my clinical experience, those patients that fail ustekinumab, if you put them on an anti-TNF afterwards, there's still a very good clinical responsive remission rate after failure of ustekinumab.
Another update question. Do you have to have any precaution using this or biologic agent in IBD in the COVID-19 situation? Canada probably have some of the cases. Thailand we do too, but we have less of IBD. So I'm not sure what precaution you need to have, in this COVID.
So there's been a couple of studies taking a look at this. So it doesn't seem that being on a biologic, whether that's an anti-TNF or vedolizumab or ustekinumab, increases your risk of having complications associated with COVID-19. So there doesn't seem to be any specific precautions, except for the fact that there is some data to suggest that the patients that are on anti-TNF have a decreased immunity over time. So their antibody responses decrease over time after vaccination. So there is a recommendation that in patients that are on anti-TNFs or other immunosuppressants, that they get a third shot or a booster dose of the vaccine. But in terms of actual risks associated with COVID-19, there doesn't seem to be any increased risk with the biologic agents as compared to patients on azathioprine or on steroids. There is some increased risk of having complications associated with these medications. So the biologics seem to be safe. The steroids and the immunosuppressives probably have a slightly increased risk of complications associated with COVID-19.
Okay, and they can get vaccine shot.
Yeah, so there's good data to suggest that the patients that are on anti-TNF can get their COVID vaccines without any problems. There's even data that it doesn't have to be weeks after your infliximab or your ustekinumab. You can do it fairly quickly after you've gotten your dose. You don't necessarily need to wait a certain amount of time before getting your COVID vaccine. So as long as you get your 2 doses, there's a pretty good chance that you'll have a response. The main issue is mainly over time that the immunity does wane in terms of patients that are on anti-TNFs, and so that's why a 3rd dose is recommended.
Okay, so I think we have learned a lot from Dr. Afif. So I thank again for stay live with us until I think now it will be almost 3 a.m. Thank you very much for your kind contribution.
Thank you again for the invitation. It was my pleasure.
Yes.